Welcome back to the Deep Dive. Today, we're really taking a focused look at percutaneous nephrostomy, PCN. It's such a fundamental procedure in IR, but it's always evolving. It demands, real precision and adaptability.
That's right.
So we're skipping the basics today. We want to dive straight into those advanced considerations, the technical steps, the nuances, and maybe some tips and tricks that really mark expert practice.
Absolutely. The mission here is really to distill what the latest expert reports are saying, give you a shortcut maybe to optimizing success and safety.
Right.
We're focusing on the details that genuinely make a difference in practice. It's about actionable knowledge you can use right away.
Okay, great. Let's unpack this then. First, critical point.
Yeah.
Patient positioning. It's definitely not one size fits all anymore, is it? It's a strategic choice.
It really is. What's fascinating is how much that initial choice impacts everything. Success, safety. It needs to be a dynamic decision, really informed by the patient's condition, their anatomy, and what you're actually planning to do.
So the prone position is still very common. You place a pillow under the ipsilateral abdomen, right?
Mm-hmm.
Elevates the flank maybe 20, 30 degrees.
Exactly. Optimizes the trajectory into a posterior calyx.
And there's the theory about Brodal's avascular plan, traversing that to potentially reduce bleeding.
Yes, theoretically. And sometimes Rolopacks under the pelvis and chest can stretch the flank even more. Positioning the side you're working on near the edge of the table helps too, just for access.
Mm-hmm.
But, the supine position has really gained a lot of acceptance.
Right, especially when prone is tricky patients with bad hearts or lungs or morbid obesity.
Precisely. And the advantages aren't just convenience, it's about better anesthetic management, uninterrupted access for interventions if needed.
Oh, okay.
Reduced risk of nerve injuries, even lower thromboembolism risk. And for obese patients, ventilation is often better.
That makes sense.
Crucially, you don't have to reposition them after intubation. That cuts down the single lung ventilation risk. Plus, the sheath angle trends downwards, which can lower intrarenal pressure, helping drainage.
Good point. Any specific tips for supine?
Yeah, keep the patient about 6 centimeters away from the radiopic edge of the table. It gives you clear fluoroscopy. And don't forget variations like Valdivia's or the Galdicow modified Valdivia for simultaneous access.
And just briefly, prone, oblique, or lateral are still options depending on the situation.
Oh, absolutely. Viable alternatives based on clinical circumstances, patient comfort.
Okay.
So the bottom line is we've moved past just defaulting to prone. Understanding why you choose a position, balancing access, anesthesia, comorbidities, that's expert practice now. It directly impacts safety and success.
All right, that's clear. Now let's get into the core technical steps. This is where precision really counts, isn't it? Gaining access.
It absolutely is. And selecting the optimal calyx, that's the cornerstone. Usually we're aiming for an inferior pole minor calyx.
Mm-hmm.
A posterior calyx is generally preferred. It gives a more direct path to the renal pelvis, less chance of injury.
And Brodal's plane comes up again here. Less about the bleeding, maybe, and more about getting that straight shot for instruments.
That's often the more practical significance, yes. A straight pathway is crucial for manipulation. For simple drainage, lower pole posterior, subcostal approach usually best.
But if you need to get to the PUJ, or upper ureter,
then you might need an upper or middle posterior calyx, possibly requiring a supracostal puncture.
Okay. And avoiding other organs, the quadrangle of safety.
Yes, a critical anatomical guide, defined by the posterior axillary line, iliac crest, parasenescent muscle, and the 11th, 12th rib border.
So it keeps you clear of the colon, liver, spleen.
Exactly. It's about proactively avoiding those injuries. Knowing your spatial relationships, understanding the risk, a few millimeters can make all the difference.
Right. Now, imaging guidance. Ultrasound seems to have big advantages.
Definitely. Less radiation for everyone, less contrast needed, lower risk of hitting major organs or vessels, especially if you use color Doppler.
Good for pregnant patients' kids.
Absolutely. And preferred for transplant or ectopic kidneys helps avoid the bowel.
Any key USG tips?
Well, good positioning and marking are vital. Identify that posterior calyx accurately. Use a puncher guide if you like. Diamond tip needles can help visibility.
What if the system isn't dilated enough?
A pre-op diuretic can sometimes help. Then meticulous observation of the needle path, confirm opacification with a tiny bit of dye, get the wire in, and check for residual hydronephrosis afterwards with USG.
And fluoroscopy.
CT. Fluoro gives you that real-time multi-angle view, great for wires and catheters. CT is invaluable for really complex anatomy, finding that precise access point, but more radiation, obviously, and not always available right there.
MRPCN for non-dilated systems.
Promising, yeah. But the key is these modalities are complementary. You choose based on the case. It's about adaptability.
Okay, so you've got your guidance dialed in. What about the actual puncture, the needle choice, the technique?
Right. Pivotal moment. An 18-gauge needle is pretty standard.
But sometimes smaller.
Yes, micropuncture sets 21 or 22 gauge are great for delicate situations. Maybe a 21 gauge in a hybrid technique. For pyonephrosis, a 22 gauge Chiba is often preferred, and again, diamond tips for USG.
And the technique itself. Seldinger is still king.
It's the most widely used, yeah, especially if hydronephrosis is less than 3 centimeters, tends to have fewer complications. You know the steps. 18G needle, J-tip wire, remove the sheath, nick the skin, pass the drain catheter over the wire.
Without the stylet.
Right. Remove the trocar, advance the catheter, confirm the coil, wire out, safety string, secure it.
Okay. What about the one-step or direct puncture?
Simpler, quicker, good for hydronephrosis of 3 centimeters or more. No separate wire or serial dilatation.
So incision, measure the distance on USG.
Yeah. Then insert the catheter with its preloaded needle directly under real-time USG. Trocar out, advance the catheter. It's faster, feels less invasive to some.
And hybrid or single stick, briefly.
Hybrid uses a smaller needle first, 21 gauge, aspirate urine, maybe dilute contrast or air, then a .018 wire, coaxials, then a stiffer .035 wire, then the final catheter. Single stick is even faster. Aspirate urine, place the tube, no contrast, ideal for PAO.
That's a mixed technique too.
Yeah, uses an 18H trocar with USG, pyelography, standard wire, then a 7/8 French catheter. Claims to cut down procedure time.
How do you know you're in the right spot with the needle?
Usually 2 distinct pops capsula fascia, then the collecting system. You'll see the needle tip move with breathing, and hopefully spontaneous urine return. If not, gentle aspiration while slowly withdrawing.
Okay. Critical warnings here, especially with infection.
Absolutely crucial. If the urine looks turbid or purulent, do not inject dye. High risk of bacteremia.
Right.
And in pyonephrosis, minimize contrast use. If you must use it, aspirate an equal volume of urine first. Prevent intravasation, prevent acute urosepsis, and never, ever overdistend the renal pelvis.
So the key is adapting the technique.
Exactly. Tailor it to the patient for speed, safety, and the best outcome.
Okay, access gained. Now, stability, guide wires, and tract dilation.
Right. Guide wire selection, often a .035-inch stiff wire, like an Amplatz super stiff. You can advance it down the ureter or just coil it in the pelvis.
And for micropuncture.
.018-inch wires. Nitinol for MRPCN. Hydrophilic wires are really helpful for non-dilated systems.
What about in pyonephrosis again?
Critically important here, don't go manipulating the wire extensively down the ureter. It's usually unnecessary and just increases the urosepsis risk.
So just loop it nearby.
Loop enough wire in an adjacent calyx to allow for the coaxial introducer exchange. That's usually sufficient and safer.
Makes sense. And dilation?
Typically serial dilators, 7 to 9 French maybe, or a single-step fascial dilator up to 14 French using controlled rotation.
Care is needed here, obviously.
Meticulous care. Prevent kinking the wire or buckling the kidney, and crucially, only dilate just to the edge of the collecting system. Don't go further in and risk tearing vessels.
So it's not just about getting in, it's about creating a stable, safe conduit.
Precisely. It requires foresight. Every step matters for what comes next, or just for stable drainage.
Which brings us to the final step, catheter placement and securement. Also critical for the long run.
Absolutely. Catheter choice, an 8 French pigtail is standard. But you individualize it, maybe 6F, maybe 12F.
Where would you go larger?
Maybe 10F for thick pyohemonephrosis or tumor debris. And definitely consider 12F for pyonephrosis to stop it occluding early with pus. Some newer techniques might use smaller initial tubes, needing upsizing later.
How do you ensure good placement and securement?
Gentle screwing motion on insertion. Get the tip well into the pelvis. For a pigtail, you want that coil nicely formed within the pelvis for drainage and stability.
And if it is a malcut?
Confirm that flower rotation under fluoro. Then robust external securement is key. Roman sandal suture, maybe a dedicated adhesive device, anchoring stitch to the skin, adhesive plaster.
And connect to the bag.
Firmly fix to the external drainage bag, yes.
Any tips for preventing dislodgement or ensuring good drainage long term?
Well, despite pigtails and sutures, catheters do slip. It happens. Early notification by staff, if it does, can often allow salvage. Simple thing, ensure adequate patient hydration. helps prevent early encrustation.
Should they flush it routinely?
Generally, no. Only if output drops, or if it's really purulent or bloody drainage. Remember, urine has enzymes that help break down clogs, so obstruction from bleeding itself is actually unusual.
So it's about anticipating those long-term issues, too. Patient education must be key.
Very much so. Vigilant home care is vital.
Okay. Now, even with perfect technique, complications can happen. How do we proactively minimize those risks during the procedure?
It requires a really meticulous, proactive mindset, hemorrhage control, infection prevention, avoiding hitting adjacent organs.
Let's start with hemorrhage. Rates reported around 1-4%, right? A major complication.
Yes. It starts with accurate puncture, ideally long axis, posterior lower calyx.
And interprocedurally.
The access sheath itself often provides tamponade for minor tract bleeding. If bleeding is obscuring your view, sometimes just repositioning the sheath helps. A flexible scope can minimize vascular injury compared to rigid ones.
Smaller sheaths help.
Correlated with lower bleeding rates, yes. If you get significant bleeding, stop the procedure. Place a nephrostomy tube immediately for tamponade.
What about post-op?
Venous bleeding post-op often stops just by clamping the tube for a bit, but copious arterial bleeding needs prompt angioembolization. Don't wait.
And bleeding from the tract itself.
Parenchymal or nephrocutaneous tract bleeding can sometimes be managed with external pressure or clamping the tube temporarily. It's about vigilance and having a tiered response ready.
Okay. What about infection and sepsis? Also critical, rates 1-10%. Maybe higher in pyenophysis.
Absolutely. Starts with fundamental adherence to pre-procedure antibiotics, especially if you suspect infection.
And during the procedure with pyo.
Be judicious with manipulation. Avoid overdistension with contrast. We talked about that. Aspirate first if you need contrast.
Right. Prevent bacterial intravasation.
Exactly. Acute urosepsis is a real danger. And consider those larger bore catheters, 12 French, to minimize occlusion from pus. Then, vigilant post-procedural monitoring is essential. It's a continuum of care.
Finally, hitting adjacent organs. Rare. 0.2, 0.5%, but serious.
Avoidance starts with thorough pre-procedural planning. Detailed imaging to confirm nothing, colon, lung, liver, spleen, is in your planned path.
Avoid going too lateral.
Definitely. That increases the risk to colon, liver, or spleen significantly.
And avoiding the pleura and diaphragm. Injury there is mostly about going too high.
Correct. Ideally, stay entirely below the 12th rib. You must understand the thoracic anatomy where the pleural reflection is, typically lower margin of 10th to 12th rib where the diaphragm inserts.
Can you go above the 12th rib safely?
Accessing above the lateral half of the 12th rib during expiration can sometimes be safe, but access above the 11th rib, that significantly increases risk. Generally avoided.
So it's really about deep anatomical knowledge, not just relying on the real-time image during puncture.
Precisely. You create the safe corridor based on understanding the anatomy before you even start the puncture.
Okay, so wrapping this up.
Yeah.
For you, the expert interventional radiologist listening, what's the big picture here? We've dug into positioning strategies, the real detailed technical steps, complication mitigation.
I think the aim of this deep dive is to equip you with a more comprehensive, nuanced view of PCN, moving away from any one-size-fits-all idea towards a truly adaptive, patient-specific strategy. That's what enhances safety and success.
And looking forward, techniques always evolve, focus shifts to long-term outcomes. It makes you wonder, doesn't it? How might future advances, maybe AI guiding the needle, smarter catheter materials, perhaps even bioresorbable ones, how might those continue to redefine the standard for PCN? And what opportunities does that create for your expertise? Something to think about.